Victoria will introduce our first speaker, Mr. Tal Golesworthy, who is a supporter and guest speaker today.
Tal, the Maverick, probably needs no introduction. A chartered engineer, he also has Marfan syndrome inherited from his father. When his aorta reached the dangerous threshold of 5 centimeters, it was decided he needed repair, but the surgical options on offer did not appeal. Drawing from his engineering acumen, he devised a beautifully elegant alternative bespoke solution. This solution is spreading across the world, and today he speaks to us from Milan. Welcome, Tal.
Thank you, Victoria. Thanks very much for the invitation to present. It's one of the parts of this project I do enjoy very much, because some of the other parts aren't quite so much fun. As some of you will know, I'm actually not a clinician. I'm a chartered engineer, and my background is combustion and air pollution control. So as you can see, my thesis was written on the filtration of flue gases in coal-fired processes. Not exactly the sort of background you might expect, but as I have Marfan syndrome and engineering skills, we'll go with that. Conscious as I am that all of us ultimately will be patients, I put this slide up really to give you an idea of some of the things that I've been through. So I really am a time-served expert patient who's had a run-in or two. The most important one, of course, is this, which is what the subject of my talk is today. Though this is going to be quite interesting to some of you who hang on and listen to Ben Clark's talk in an hour or so's time. Ben very courageously took on a one-eyed Marfan man with a cataract and has done a fantastic job, and I'm extremely pleased with the outcome, as I think is Ben. Okay, I knew I had Marfan from a child. I had dislocated lenses as a youngster before I lost my eye. I was identified when I was about 6 or 7. I just thought, oh, well, it's eyes and it's skeleton. In 1992, I went along to one of Anne's genetic info days at St. George's and had my aortic root measured. And to my horror, it wasn't down in the normal zone where it should have been. It was actually up here. And at that time, about 5 centimeters was the point where intervention was indicated. So I started an annual trip to various hospitals to have my aortic root diameter measured. I did all the usual things, denying it was happening, pretending it wasn't there, and all the rest of that stuff that we all go through. And then eventually in 2000, I just thought, well, I've got to do something about this. I'd been talked through total root replacement. I was horrified at the thought. Sorry for those of you who have had total root replacement. I'm certainly giving my response to it. So in 2000, again at St. George's, I went to a Marfan Association info day where Professor Tom Treasure was talking about aortic root replacement. So in the Q&A, I sort of put my hand up and said, hey, you got this wrong, Sunshine. This is what we should be doing. To his credit, Tom embraced the ideas, and we then ran between us a feasibility project. So I put together a team, including an engineer from Imperial, Professor John Pepper as our surgeon from the Brompton. I started a company, raised the money, ran all the project, and then in 2000, excuse me while I move that's better. In 2004, I had the first operation. So it took us 4 years to get from my ideas to a realization. I had the first operation, and the reason this graph stops at 2004 is my aorta has remained the same size ever since, which is just what we wanted to do. So this was the 15th anniversary in 2019, I think, at the Athenaeum. And this is Mike Rubens, a cardiologist at the Brompton. This is Tom Treasure, with whom I started the project. This is Dr. Thornton, who's our computer-aided design engineer. This is John Pepper, who did the first 22 PEARS operations without any proctoring. This is Rad Mohyadin, the MRI expert at the Brompton, who helped us with much of the initial scanning work. This is Andreas Hoshtytsky, who's a PEARS surgeon at the Brompton. This is Conor Austin, who has now done more than 200 PEARS operations. And this is our CEO, Peter Gibson. So the bit we're concerned with is what's called the aortic root by some, the ascending aorta by others. So this is the left ventricle pushing blood up through the aortic valve. And you can see 2 of the leaflets of the valve there, opening and closing. So this is the aortoventricular junction. This is the aortic valve. This is the sinotubular junction. This is the ascending aorta, and this is the brachiocephalic artery. This part is the part that normally suffers most with people with connective tissue disorders because it's the largest diameter pipe in the system, and the tensile load is therefore fairly large. So that's the bit we're actually talking about. This is a horizontal section through me, and you can see that this is the aortic valve. So this is a key part. We need to protect these three sinuses of the aortic valve to stop them dilating, which can lead to dissections and various other problems. This is a static picture showing you the AVJ at the bottom. These will be the coronary arteries coming out. This will be the aortic valve in this area, then the ascending aorta, and then the branching arteries from the arch. Now, normal root replacement runs from about here to about here, because this part is where they put the cross clamp on you. Now, our device runs from the base right up to the brachiocephalic artery. So we actually conserve all of the ascending aorta, and we preserve it and protect it rather further than would be the case with root replacement. The problems associated with dilation, first of all, is that if you stretch those sinuses, the valve will start to leak, regurgitation. So that's a disadvantage. A dissection is much more serious when the intima and the media, the inner two layers of the aortic wall, can tear. That can be a very, very dangerous situation. And then rupture is almost the best of the three, because you're probably dead before you hit the floor, so you don't know a thing. Doesn't happen very often now, I'm pleased to say. But anyway, these are serious problems, so we need to address them if we want to live a reasonably long life. This is my project aim, and it's actually a very, very simple one. I wanted to make a device which is going to perfectly fit the aorta. Other surgeons previous to this had tried ad hoc wrapping with the wrong materials around a very funny shaped aorta, and they had very, very mixed results. Basically, it didn't really work very well. But the fact that PEARS is engineered and made to measure for each patient means this external support now can work. And in fact, Francis Robichek, one of the great proponents of ad hoc wrapping, saw a PEARS presentation at a conference in Lisbon and congratulated Tom Treasure very warmly on achieving what he himself had been trying to achieve his whole life and had failed to do. So how do we do it? Well, we stick you in a CT scanner at one of the hospitals. We do a standard scan gated into diastole. That's the part of the cardiac cycle when the heart is relaxed and the aorta comes down to its minimum size. We use contrast agent to get good high quality pictures. Whoops. And we go from the left ventricular outflow tract below the valve to the top of the arch, and we take standard DICOM file output. We then put those into a special program which Dr. Thornton wrote for us, an extent. He and I worked on that together at Imperial. And this is an example of one of the parts of the output. This is the CT image of the particular patient. This is the image, a transaxle image of the aortic valve, the gray shape. And the two red lines are the inner and outer wall of our model of the aorta. And the outer wall needs to fit the CT shape of the sinuses. And as you can see, it's a pretty good fit. The gap between these two lines, by the way, is 4 millimeters. So that gives you a measure of how close the fit is. This is a side view of the aorta. So we have the left ventricular outflow tract down here, the aortoventricular junction, two of the valve leaflets, the aortic valve area, and the ascending aorta. And you can see that the fit of that computer model is really, really pretty good. We are very pleased with that functionality. And have used the same program for the last 18 years. Essentially what we're doing is we're taking a series of measurements from your own aorta and we're turning them into this computer-aided design model of your aorta. So that's what a CAD model looks like. It isn't just a 2D picture, it's a 3D device living in computer memory. This is actually the CAD model of my Marfanoid aorta. So you can clearly see the three sinuses of the valve at the bottom. That's the left coronary sinus, that's the non-coronary sinus, and that's the right coronary sinus. And you can see it's a very difficult shape. So trying to just wrap something around it is actually completely stupid. It's just not going to work, which is why the ad hoc wrap has really failed. When we have that CAD model and the surgeon has signed it off, he looks at a report, he looks at the fit of the CT to the CAD. We then produce a physical model. So we take that CAD model, feed it into 3D printing machine, and we get a rigid physical model of the patient's aorta. This explains why it needs to be personalized. Every aorta is different. Even the healthy ones are all varied. We actually did a couple of 15-year-old identical twins, Isaac and Aidan, and I still can't tell them apart. They are identical. They live in the same house. They go to the same school. They play the same basketball. They chase the same girls. They drink the same beer, and their aortas were completely different. So the idea that one size fits all is nonsense. It has to be customized to each patient because they're all different. Once we've made that former, we then use that to form the actual implant, which is a very, very soft, porous textile device. You can see there. They're actually Tom Treasure's hands, for those of you interested. So this device is formed on the former, and it takes the shape of the former. So when the surgeon opens up this device and takes it off the former, he opens up this axial seam, which runs all the way up the device right to the top, and puts it around the aorta. He knows it's going to be a perfect fit. We can also scale the device on diameter. So if, for example, we have a patient whose sinuses are dilated quite a lot and the valve is leaking, we can make a 95% or a 90% or an 85% device. The surgeon can drop the patient's blood pressure on the operating table. The aorta shrinks. He puts the undersized device on. He brings the blood pressure back up. The aorta grows back out to, say, 80% of its previous diameter. But because it's only 80% of the diameter, we've brought the sinuses together. We've brought the valve leaflets together, and we have recovered valve function. This has happened in over 200 cases now, where we have recovered valve function as well as supporting the aorta. This is a great, great second win for the patient. This is a slide for the surgeons. They all say, "What's it made of?" And you say, "Well, the material is polyester, which one of whose trade names is Dacron, and it's exactly the same in a root replacement graft as it is in PEARS. But the textile is completely different. The root replacement graft is a stiff, hard, sharp, woven textile. Ours is a very, very soft, knitted textile, and they have completely different mechanical properties." And I got all that from the work I did with fabric filtration when I was working on flue gas cleaning, which is quite strange and serendipitous, but it's absolutely the case. One of the key differences is our material, because it's very, very porous, can completely incorporate into the adventitia, the outer wall of the aorta, where the very stiff, tight, hard, woven root replacement graft cannot. So they're very, very different properties. The surgical implantation is done on a beating heart. You don't need to use cardiopulmonary bypass. In fact, there are lots of advantages to not doing that. You don't need any hypothermia. You don't need any cardiac arrest. So you have a shorter operation and you don't feel quite as awful as you might otherwise feel. This is actually John Pepper training this surgeon, Peter Kacher, who I just met the other day. I'm at the EACTS meeting in Milan this week. This is Peter Kacher, and we're in FNKV in Prague, where this lady with the patient was a lady with Loeys-Dietz, had PEARS surgery. She was in her 40s. She went home after about 5 days and rang the surgeon afterwards to say, that was really great, thank you. Can you repair my two sons who both have Loeys-Dietz as well? So it's a shorter operation and a much less invasive operation than root replacement would be. So does it work? Well, this is these are some MRs of me. These are side views of me. So that's my sternum down the front, and there's my spine down the back. And you can see from my aortoventricular junction round my valve up to my brachiocephalic artery, that shape is essentially the same as that shape. It's actually impossible to get someone back in an MRI scanner in exactly the same position to get exactly the same view. But the one was done in 2004 before my surgery, and this was done in 2014. I'd give you the one from 2022, but they're all the same. So is there any point? My aorta has remained dimensionally stable for over 18 years. The valve is fully functional, no dilation, no dissection, no drugs, blah, 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 blah. We can just all go home and have a beer, which is exactly what we want to do. So where are we today? Well, I updated this on Tuesday before I came out to Milan, and it was 688. It's actually 691 now. So we've done quite a lot of patients now. We're up to a large number of post-operative patient years. There's quite a group of us with more than 10 years, of which I'm very pleased I'm at the front. Quite a group of us with more than 5 years. Our youngest patient was a 3-year-old girl in Brisbane with an adult-sized aorta. You cannot put this on a pediatric aorta. You can only put it on an adult-sized aorta because it won't grow anymore. Our oldest patient was a 77-year-old, I think, in Prague about 3 weeks ago. So we cover a whole range of ages, and you can see a lot of us are in our 20s and 30s. That's a big bulk of the people. And that's, I think, typical of probably the sort of age range where people with Marfan's died before there were any surgical options to treat them with. We started off with Marfan syndrome. You can see we've moved out into lots of other areas. Don't worry about the ones towards the bottom of the screen. They're not necessarily relevant, but this top group are all what are called aortopathies. So Loeys-Dietz is a similar connective tissue disorder to Marfan. Marfan is still the leading group. Bicuspid aortic valve, slightly different, but again, it's an aortopathy. It's a genetically indicated disease. Idiopathic is an interesting group. These really are the ones that aren't in families and don't come in groups and just appear. And it's really nice. I think as a patient, I'm very pleased to see so many of these people being identified before disaster strikes and then being sorted out with PEARS and being protected from any further problem. I was rather surprised that we've only done one Ehlers-Danios. I was kind of expecting right at the start that we'd see lots of Marfan, lots of Loeys-Dietz, and lots of Ehlers-Danios. We've only actually done one so far. We've done a tophotracheophalange. We've done a few actor twos. I think there are going to be more of those coming through as well. Looking just at the aortic pairs, because we're doing Ross pairs as well, which is a separate operation, we've actually now done not 590, we've done 521 on intention to treat. We've only completed 602 cases because variously surgeons have taken a look at an aorta and thought this is very thin, I'll do a root replacement. So we've done a fair number of conversions to root replacement of biobental. We've done some valve sparing root replacements, a Florida sleeve. A couple have had interposition grafts. One patient had such a bad pectus, the surgeon decided he would just repair the mitral valve and not look at the aorta. So these are the practical realities of surgery. It doesn't always go to plan. Sometimes things go wrong and you have to bail out and take another route. We still have only one perioperative mortality. It's one too many, but you know, we live in an imperfect world. When poor old Ewan bit the dust, he was patient number 36, so he was 1 in 3. He's a 3% error. He's now 1 in 690, so he's a 0.2%. Tragic for him, absolutely tragic for him. But in terms of the reality of surgery, you know, all surgery carries a risk. This is a very low perioperative mortality. We've had a few redo operations. These weren't true redos. These were operations where during the learning curve, something wasn't done quite right. So we've had sort of 4 or 5 redo operations. All the patients are fine. None of them have had any difficulty. This is a table I wish all clinicians would put before all patients, because if you put that in front of me, and I wasn't aware of how difficult the PEARS surgery was, so I didn't have to worry about the surgeon's stress, I think this would be a complete no-brainer. I can't see anyone in their right mind, if they were given these 3 choices, would actually choose anything other than PEARS. A short operation, no cardiopulmonary bypass needed, no body cooling, no anticoag for life. In fact, I take nothing. I take no drugs to manage my aorta now at all. I take some drugs to manage a stent I have in my left anterior descending coronary artery, but I mean, I only take them to keep the cardiologists happy. I don't really think that I really need to bother. So, I mean, I can't see why anyone in their right mind would not choose PEARS. I entirely respect their decision. If they want to have total root replacement or valve sparing, then that's up to them. I think the sad thing is that most patients are not shown this table and do not know that PEARS is an option, and I think that's a great shame. It took us 13 years to do our first 100 cases, 22 months to do our second 100, 11 months to do our third 100, about 7 months to do the fourth 100, 6 months to do the fifth 100. But as you can see from the graph, apart from the slowdown that COVID caused us, we're going the right way. So more and more patients are getting access to PEARS, which I think is beneficial because it's going to give them a shorter operation and a better quality of life. Incidentally, I'm still amazed by this. Helen, I've got a lot of friends in the PEARS patient group, so I use their names, knowing them as friends. Helen was 21 when she had her PEARS op. She had her operation on the Wednesday and she went home on the Saturday. There is no chance in hell you could have a root replacement operation and go home 4 days after the operation. But PEARS is short and quick, and you can do it. These are our surgical centres around the world now. In fact, we've just started one in Italy. We're about to start another one in Portugal. We're about to start in Hungary. We're about to start in Saudi Arabia. And we've just got an ISO accreditation, which means we can go into the USA in about 4 to 5 months. So it is growing now, which is great news for patients in terms of patient choice. These are the UK centres. So any of you who are interested, who are sadly in the position of having a dilated aorta, but one which is asymptomatic, these are the centres that you could go and have a chat with the surgeons at. I'm not sure I would have a preference. Mario is very, very good at the Brompton, likewise Andreas. But anyway, you have some choices there. So wherever you are in the country, there should be a hospital not more than about 80 or 90 miles from you. This is really a technical rather than patient perspective. I think it's what fascinates me about PEARS, and this is expressed in my TED talk. We put together a multidisciplinary team, not just a bunch of medics or a bunch of engineers, but we put ourselves together in a team. And Tom Treasure, John Pepper, myself, and Warren Thornton had sufficient mutual professional respect to get to a really, really good solution very, very quickly on an embarrassingly small amount of money. I would argue that PEARS is technically superior to total root and valve sparing root. You keep all of your own tissues. The device incorporates into your adventitia to form a completely stable device. You don't really need to take any drugs. Why would that not be better than total root where you're on anticoagulation, or valve sparing root where you're running the risk of reoperation? I think PEARS is the ultimate tissue sparing solution for those of us with dilated aortas. Patient operative stress is massively reduction. If you have a 2-hour operation without any cardiopulmonary bypass, you wake up and you feel pretty good. I spoke to our first patient in the Netherlands, Seawing, 2 weeks after his operation, and he was saying, "Oh, I'm really bored. I want to go to work. I want to be able to drive my car. I'm bored staying at home." So, I think that's the ultimate accolade for any surgery, that people can recover so quickly and feel so good. I guess it took me, I was 47 when I had my op. I guess it took me probably a couple of months to really get back on my feet. You do feel like you've been run over by a lorry when a surgeon's run a pneumatic saw up your sternum, but there it is. That's what it's about. Probably the most important probably the most important point on here is this one. As the world population rises and healthcare systems are under more and more stress, we've got to get better solutions at a better price. Now, the PEARS implant is more expensive because it's custom made, but the operation is short, the stay in hospital is short, and the patients don't come back. So this is a great example of a really cost-effective solution which gives the patients a better outcome and saves the healthcare service a lot of money, and that is going to become increasingly important in an increasing number of countries over the next few years. A lot of us involved in this, it would perhaps be iniquitous to name any single names, but I would say Tom Treasure for having the vision and the open mind not to ignore me. It's been a delight working with Tom, and I think he and I and John Pepper between us have changed the world. So I would put Tom Treasure and John Pepper as absolute giants of cardiothoracic surgery. I've got the ultimate respect for them. I still work very closely with both of them, and it's a total delight. Apart from the fact they're both 10 years older than me, and they can still both outwork me, which is a little bit tedious, but there you are. Lots and lots of info up on extent.com, all the medical publications, lots of lovely film and video and things, lots of patient reports. So if you're having a bad day and you're feeling rubbish, go and look at some of the patient experiences and you will feel very, very much picked up. Thank you very much for your attention.
Thank you very much, Tal. Your website is a trove of information. Sarah has a question. Sarah wonders, can the same principle be applied to a dissected aorta, say in the descending portion, i.e. reinforcing an otherwise weakened wall?
Two questions there. We can only treat aortas which have not dissected. If you've dissected, I'm talking now about the ascending aorta. If you've dissected, essentially you've got to have a root replacement. That's why it's good to get in early, get to look at your aorta when it's 3.8, 4, 4.5, and then make an early move to have prophylactic pairs rather than waiting till you dissect. As far as the descending aorta is concerned, dissections can be treated by endovascular techniques, which is an entirely different approach. In terms of external support in the descending aorta, the access is very, very difficult, and there are many, many branching arteries from the descending aorta, which make it incredibly difficult to put a pairs in place. I have looked at this. I've attended an abdominal aortic aneurysm repair operation, and it's really not practical. I mean, I would say that the treatments available, the endovascular treatments available, have got a very good clinical track record. So I would say you're happy, you're going to be fine with those. So I would stick with those.
Is that, sorry, is that so at the moment I've got a frozen elephant trunk that was done in Birmingham QE by
yeah. So that's an endovascular repair of that part of the aorta which it was applied to. Yeah.
Right. Okay. Thank you.
No problem.
And Mariam wonders, is this procedure available on the NHS?
Yes. Virtually all the UK cases are done on the NHS, apart from people who have come from the USA, Bolivia, and Brazil to have it done privately, and Germany and France have had it done privately in London. Virtually all the operations are on the NHS. It's important to know that if you are a UK resident, you can ask your GP to be referred to any clinician you like. You don't just have to go to your local hospital. If you want pairs, look at the website, choose the site you want, the centre you want to go to, and go to your GP and say, I would like a referral to Mr. Mario Petru at the Brompton or Mr. Connell Austin at St. Thomas's, and they are required to do that for you. So you don't need only to go to your local hospital. So you can get a referral anywhere you like on the NHS, in the NHS.
And someone asked me by email, they've been told they're anatomically unsuitable for the PEARS procedure. They didn't elaborate on why.
Yeah, I think it's true to say that whenever any new treatment develops, at the outset, surgeons are very, very cautious. They want to look at cases which are uncomplicated, which they can be successful with, which they can then learn from. And then as their experience develops, the indications for the treatment widen. I haven't heard of any people in the last year who have been refused pairs on anatomical reasons from a properly trained pairs surgeon. Certainly 8 or 9 years ago, I know 1 or 2 people who were not offered pairs because there was some anatomical. I mean, cabbage is a great example. If you have some coronary artery disease, 10 years ago, they would have told you to go away. Now it's routine to do pairs and coronary artery bypass grafting at the same time. So as I say, as the knowledge experience extends, so contraindications will probably back away and reduce. I was very lucky. I had a nice big aorta with nice big coronaries, only 2 of them. Yes, there are sometimes more than 2. I've seen one aorta with one coronary, and I've seen another aorta with 4. So the idea that you have a left main stem and a right main stem might look nice in the textbooks, but it ain't always quite right. I mean, the anatomical studies I've done on CT of hundreds of diseased aortas have been a real education to me on the variability and the variation within the biology and the anatomy of the aortic root. Fascinating subject.
Yes, I think Leighton just wants you to know my son had PEARS and mitral valve repair in the same surgery in December. Amazing stuff. Yeah, and I think it is, because you can go in early, repair a slightly dilated aorta, stop it moving, and the patient can just
go home and get on with their life, which is exactly what you want to do. You don't want to be coming back because it's difficult for you as a patient, and it costs the healthcare service a lot of money. Sadly, having had PEARS surgery and having had lens replacement, I now find that my iliac arteries are dilated, so I'm going to have to go and have iliac surgery, which is another load on the NHS, which I don't want to give it, and another interesting challenge for me. But there you go. In my next life, I won't have Marfan syndrome.
Tal, can I ask a question, please?
Please do, Anne. Please do.
I'm really impressed with the fact that this operation is being used in children now.
Yeah.
And I hear that a very young child has been operated in Australia. Can you tell us? Can you tell us why the children are being operated on?
Well, this particular child, I think, was a 3-year-old, but they had the aortic sinus size of an adult. Their sinuses were already at 4 centimeters. So clearly, and in that sense, we're not operating on a child, we're operating on an adult. The bit of the anatomy we are going to support is adult sized. It's not child sized. We would not operate on a pediatric sized aorta because it's got to grow with the child. But this particular child had a 4 centimeter aortic valve at age 3. So clearly they've got a very aggressive form of Marfan syndrome, which is going to kill them unless something is done. So what the surgeon did in that case was he put the implant on from the aortoventricular junction at the bottom of the valve up around the valve, and then he left the upper part of the implant open. So the ascending aorta, which was still relatively small, pediatric, can grow, but the valve will stay at the same size. So the issue is we are operating on adult-sized anatomy, irrespective of the age of the patient. We've done, I think, about 7 patients less than 10 years old, but they've all got adult-sized anatomy. So we are protecting adult-sized anatomy irrespective of the age of the patient within which that anatomy exists.
Brilliant, thank you.
Sinead wonders, I don't know whether you've already answered this, how are cases in children treated?
With great caution. Nobody likes seeing children die, and everybody wants to scream hatred at the surgeons who kill them. So with great caution. But as I say, we will only treat adult-sized anatomy, aortic anatomy, inside a child, because the pipework has to grow to provide sufficient blood for the organism to live. So it would be insanity to do a procedure like this, which will fix the size on a child-sized piece of anatomy. It has to be adult-sized anatomy.
Just searching for questions. Nothing's emerged in the chat feed. Nida has a question.
Oh, no, I just wanted to say that in my experience, the children who've had PEARS have done extremely well. And the feedback from them immediately after the operation and afterwards is really excellent. So thanks to everything that Tal's done. An amazing talk. Thank you.
We did a young congenital case, a little 11-year-old who'd had a septal defect repair. He'd had an aortic switch operation. He'd been in and out of hospital. He'd had about 4 major cardiac procedures, and he was only 11. And we did a slight variation on PEARS, which was hugely successful. This is Connell Austin at St. Thomas's. And I rang his mum about 2 weeks after he'd gone home. I said, how's the little one getting on then? He said, oh, he's playing football. He's back at school. He's even swearing at his mum, just like he was before the operation. So it's really, kids are so adaptable and flexible and repair so quickly. It's a real delight to see that take place. But that lad's life has now been transformed. His right coronary sinus had dilated so far that it was stretching his right coronary artery and forcing it against the inside of his chest, pericardium, such that he was experiencing angina as an 11-year-old. So we did a very, very special PEARS for him, where we brought the size of the right coronary sinus down to something that matched the other 2 with a very, very specialized implant. And so the surgeon did a bit of an aortoplasty on the front sinus, on the right coronary sinus, brought it down, completely took the stress and pressure off the right coronary artery, and the guy is totally okay. And he's now, I don't know, 6 years down the line, and he's living a completely normal life and no problem.
And Sarah Stillman has said, my son and I were operated on in the same week at the Royal Brompton. We were numbers 6 and 7 in PEARS. Thanks, Tal, for all your support. We couldn't have done it without you.
If they'd known how much aggravation John Pepper got from the clinical practice committee doing 2 patients with the same initial and the same surname in the same week, they'd be even more impressed. John had to move heaven and earth to make that happen, because very rightly, good clinical practice says don't do 2 patients with the same name and the same initial in the same week, because you might mix the bloody things up and then you'll be in deep trouble. But yeah, no, it's great to see Sarah and Sam doing so well. You
mean administratively just mix them up?
Yeah. Because, you know, mistakes can happen. It's dead easy. Oh, S. Stillman? Yeah, this is S. Stillman. Yeah, no problem. That's why they very, very carefully. What's your name? What's your date of birth? What's your hospital number? Tal Golesworthy, 10 12 56 D75495. Yeah, but it's, you know, I don't think we appreciate it. We are so lucky in the UK to have a health service with outstanding people in it. I mean, Colin Austin, John Pepper, Tom Treasure, these are outstanding clinicians, and it's all free at the point of use, and we all take it for granted and whinge and gripe about it. I recently had lens replacement surgery, which you can hear about in a minute. Very, very high stress experience for the surgeon involved, all done on the NHS. I wrote to the Times to say, you know, it'd be really nice if when the NHS did something really great, we celebrated it. Here's a fantastic example. One-eyed man, lens cataract, 65, Jesus Christ, this is tricky. And what an outcome. And the miserable buggers wouldn't print it. It makes me despair. If you're going to print the bad, you should be printing the good as well. And the NHS does so much good. We should all treasure it, look after it, not abuse it, and be incredibly proud of it, but also feel incredibly fortunate that we've got access to it. If I were living in the USA, I'd probably be dead by now, because I wouldn't have been able to earn enough money to pay the bloody health insurance to get a root replacement. That's the truth. So enjoy and respect your NHS.
And Roshana has said, thank you very much. Great talk, Tal.
Lovely, thank you.
So any further questions for Tal? I'm just scrolling.
We'd like to know what you're doing where you are.
I've been standing on the Extent Limited exhibition stand at the European Association of Cardiothoracic Surgeons Milan meeting, and my hypermobile Marfan feet hurt like hell. My spastic Marfan back is aching like hell, and I'm really enjoying sitting up here on a soft seat giving this presentation, because it's much better than standing on the stand. But I will go back down to the stand to support our new managing director, Victoria Sharp. So I'm at the X meeting, so I'm on exhibition stand duty. But you really don't want to be doing it with Marfan syndrome. You really don't want to be doing it.
And Charlotte Nason has said, thank you so much for a wonderful, helpful presentation.
Great.
And Sinead has said, brilliant, thank you.
If anybody wants to ask other questions, I'm sure that Victoria will just email them to me, so there's no problem. I hope the presentation was sufficiently complete and comprehensive that most people have all the data they need. But the Extent website is a great place to go, especially when you're having a really bad day. Go and read some of those patient stories. They really will pick you up. They really will pick you up.
There's a lovely story of the lady. Is it the lady who travelled from America to be treated privately by you?
Mattia, yeah.
That's right.
Yeah, absolutely fantastic.
And she swooped out back home. It was just astonishing.
She came over to the UK and had PEARS privately at London Bridge Hospital for about £60,000, quite a lot of money. She went back home to Oregon, watched her dad go through total root replacement and not do too well, charged at $250,000. Because it's healthcare is a money go round in the USA. It's not about patients and healthcare, it's about people making money. But yeah, lovely. I had lunch with Mattia a few days after her surgery. Lovely girl. Got a lovely little daughter as well. Fantastic.
If there are no further questions, all that is to say is thank you for such a bouncy and buoyant and insightful talk, Tal.